Okay, we're skipping the fluff today and jumping straight into the clinical algorithm for pediatric and adult airway emergencies. Our goal in this explainer is to completely break down the exact test day logic you need to confidently differentiate a sick patient from a not sick patient. We are mapping out everything from upper airway infections to deep neck space emergencies. Let's get right into it.
Section 1, Airway Triage and Stridor, the primary survey. The absolute most crucial point is identifying red flags right from the doorway. If your patient has a toxic appearance, if they're leaning forward in that classic tripod position, if they're drooling or showing severe respiratory distress and stridor, you have to stop right there. Don't agitate them. Absolutely do not force an oral exam. You need to secure that airway with 100% oxygen, potentially using video-assisted endotracheal intubation in a highly controlled setting before you do anything else.
To build a solid mental framework for a noisy, stridorous airway, we divide the causes into acute versus chronic presentations. Acute stridor is typically infectious, so you're thinking croup or epiglottitis. But if that stridor is chronic, you need to pivot to anatomical issues. For example, laryngomalacia is a floppy supraglottis, where the stridor actually gets worse when the infant lies supine. On the other hand, a vascular ring compressing the trachea actually improves when the neck is extended. And airway hemangiomas, they'll typically show up alongside skin hemangiomas in a beard distribution. Section 2, the larynx and trachea, bark versus drool. When we're differentiating primary upper airway infections, it's a classic matchup, laryngotracheitis versus epiglottitis. Laryngotracheitis, which we all know as croup, is mostly driven by the parainfluenza virus. It shows up with hoarseness, inspiratory stridor, and that famous barking, seal-like cough. For moderate to severe cases, we're treating with nebulized racemic epinephrine and steroids. Now contrast that with epiglottitis, which is rapidly life-threatening. Driven by bacteria like strep pneumo or H. flu in unvaccinated folks, these patients present with a muffled voice, severe dysphagia, and drooling. Simply put, they don't bark, they drool. Because epiglottitis moves incredibly fast, your very first move has to be an early artificial airway if respiratory failure is impending. If you have a single failed attempt at intubation, that should prompt a surgical cricothyrotomy to bypass the swelling completely. Medically speaking, you are hitting this hard and fast with IV antibiotics, specifically ceftriaxone plus vancomycin. You've probably heard of the classic thumbprint sign. It's caused by a severely inflamed, swollen epiglottis. But here is the critical thing to remember for test day. This is not just a pediatric illness. This severely thickened epiglottis happens in adult patients too. If you spot this thumbprint, you are dealing with a severe acute airway emergency, period. Let's test this logic with a high-yield clinical scenario. Imagine you've got a patient presenting with croup-like symptoms, a barking cough, and a fever. Naturally, you suspect croup, and you give them racemic epinephrine. But they show absolutely zero improvement. And worse, they look highly toxic. What's your next move? You've got to pivot your differential immediately.
That total lack of response points directly to bacterial tracheitis. This is most commonly caused by Staph aureus. It usually follows a standard viral prodrome, meaning the kid had a normal cold that suddenly just got way worse. The key markers here are the toxic appearance, thick, purulent secretions, and the complete failure of racemic epinephrine to do anything. Management means securing the airway, getting an endoscopy for a tracheal culture, and starting aggressive IV antibiotics.
Section 3, the deep neck spaces and contiguous spread. Understanding deep neck fascial layers is absolutely critical. The retropharyngeal space sits directly in front of the danger space, and that danger space extends continuously all the way down to the diaphragm. This means a localized retropharyngeal abscess, which might have started from a simple viral URI or a penetrating trauma like swallowing a fishbone, can spread directly down into the posterior mediastinum. When that happens, it causes acute necrotizing mediastinitis, which is literally a worst-case scenario. Differentiating these deep space infections really comes down to binary logic. If a young child comes in with a fever, a muffled voice, and a rigid refusal to extend their neck, that points straight to a retropharyngeal abscess. Why? Because extending the neck pulls painfully on that inflamed posterior pharynx. On the flip side, if an adolescent comes in with severe trismus, meaning they basically can't open their mouth, that is the calling card of a paratonsillar abscess. When you grab a lateral neck x-ray for a retropharyngeal abscess, it's going to show massive soft tissue swelling, literally pushing the airway forward. That widened prevertebral space confirms the diagnosis and perfectly explains why the child is in so much pain and absolutely refuses to extend their neck.
Conversely, on physical exam, a peritonsillar abscess typically presents in an older adolescent or adult. They'll have that classic, muffled, hot potato voice, but the dead giveaway when they finally manage to open their mouth despite the trismus is severe unilateral tonsillar swelling that's visibly pushing the uvula away from the affected side. So, what's the game plan for peritonsillar treatment? Step 1. Always assess and secure a compromised airway first. If they're in a tripod position, don't rush in to drain it. Secure the airway. Step 2. Get a CT scan of the neck with contrast if you suspect the infection has spread deeper. And Step 3. Definitively treat the abscess with needle aspiration or incision and drainage combined with IV antibiotics.
Section 4. Physical obstruction. Ruling out foreign bodies.
All right, let's look at foreign body aspiration. The classic story is a sudden onset of choking, followed by focal, unilateral wheezing and diminished breath sounds on the affected side. Due to the anatomy of our bronchial tree, the aspirated object most often ends up down in the right mainstem bronchus. If you percuss the chest, you might even find hyperresonance over the hyperexpanded lung on that specific side. Here's the kicker. A totally normal chest X-ray does not rule out a radiolucent foreign body. Up to 30% of radiographs in these cases will look perfectly normal, especially if the kid swallowed a piece of food instead of a metal toy. If your clinical suspicion remains high despite a clean X-ray, rigid bronchoscopy is the immediate next step. It acts as both your definitive diagnostic tool and your therapeutic intervention to get the object out. To lock all of this in, mastering these specific infectious and physical distinctions will save lives in the ER and save your score on test day. But as you continue your prep, ask yourself, what happens if that airway compression isn't an infection at all? How will your algorithm pivot if that neck mass is a branchial cleft cyst, or worse, a mediastinal mass like a thymoma or a terrible lymphoma? And what if that sudden chest pain and dyspnea isn't an aspiration, but a spontaneous pneumomediastinum presenting with a Hammond crunch? The differential never stops expanding. Keep building your structured logic, and we'll catch you in the next explainer.